In the last presentation, we had placed the posterior abdominal wall. The vertebra was in the center, the iliac crest and the 12th rib. These formed the bony background. Then we had placed the median arch, the medial arch, and the lateral arch of the origin of the diaphragm. We had placed the central tendon of the diaphragm and the inferior vena cava. And then we had passed the iliopsoas, the psoas, the iliacus component, and the quadratus lumborum, the thoracolumbar fascia, from which arises the transversus abdominis, internal oblique and external oblique. The internal oblique splits to enclose the rectus abdominis and ends in the linea alba. So we had drawn all this. Now we continue to place the nerve, the vessel background, and then the viscera in the abdomen. So then this was the medial arch on the vertebral column, the medial from the body to the transverse process, and from the transverse process to 12th rib. And here you see the diaphragm. From the right crura you see the hiatus for the esophagus, and this is the central tendon, and you see the inferior vena cava here. Now from the medial arch, under the medial arch arises the iliopsoas, which combines with the iliacus, and from the lateral arch you see the quadratus lumborum, and then there is the thoracolumbar fascia in this region, and finally the transversus abdominis, outside which is the internal oblique and the external oblique. So this was the posterior abdominal wall that we had studied. Now in the center we place this sympathetic chain, and from the lateral border of the iliopsoas, crossing the quadratus lumborum, are the iliofemoral and the genitofemoral nerves. So then from the lateral border you have the lateral cutaneous nerve of thigh, which sometimes pierces the inguinal ligament and is responsible for the meralgia paresthetica. From piercing the iliopsoas itself is the obturator nerve, and from the medial, under the medial border of the psoas arises the femoral and the sciatic nerve root to the sciatic. Here is the opening of the inferior vena cava. Here is the central tendon. Here is the hiatus for the esophageal, for the esophagus. Here is your quadratus lumborum and psoas, and here is the origin of the iliacus. And so I have labeled this nervous background of the abdomen for you. Now we place the veins. So the veins in the gutter, besides the sympathetic trunk, there is the artery and vein. The veins are the azygos veins, the right and the left. There is the cisterna chyli, which is the lymphatic chain, this white thing that you see here. And this is the subpostal vein. And the artery is very important. The artery is called the arteria magna of Adamkiewicz, because these arteries are formed by the superior and inferior divisions of the lumbar artery. They are behind the psoas, and they actually enhance the supply of the spinal cord. So these connecting arteries, which connect the posterior spinal and anterior spinal artery and support them through the intervertebral foramen, are called as arteria magna of Adamkiewicz. Now we place the kidney. The posterior relation of the kidney would be the diaphragm, the psoas, the quadratus lumborum, and the transversus abdominis. Above the kidney, you have the suprarenal gland. This is the ureter, which is crossing the pelvic brim and going to the bladder. From the under the median arch has arisen the aorta, which is divided into the common iliac artery. This aorta gives an inferior diaphragmatic. It gives two types of branches: paired, that means right, left, and central. So the central branches are the celiac axis, the superior mesenteric, the inferior mesenteric, and the median sacral. The paired ones are the inferior diaphragmatic, suprarenal, renal, the four lumbar arteries, and the common iliacs. The common iliac supplies the iliolumbar branch and divides into the external and internal iliac. And we'll study the internal iliac in greater detail, but the external iliac continues into the femoral artery. So this arterial background and the kidney we have been able to place in the second. The third is we'll now place the esophagus, which has got a first part, a second part, a third part, which ends in the ileum, which is the duodeno-ileal junction. From the central tendon of the diaphragm comes the IVC, and over the IVC we have placed this duodenum. So this duodenum has got a first part which passes from the free edge of the lesser omentum into the retroperitoneal area. So this connection between the free edge of the lesser omentum and the retroperitoneal area is called as porta omentale. And through this porta omentale passes the hepatic artery, the portal vein, and the bile duct. And there is an artery branch of the hepatic artery. One is the right gastric branch and one is the supraduodenal artery of Wilkie, which supplies the anterior wall of the duodenum. Now, since this is an end artery, therefore duodenal ulcers are found mostly in the anterior part of the duodenum. The second important thing is that the bile duct comes behind the first part of the duodenum, combines with the pancreatic duct, and opens into the ampulla of Vater in the second part. The third thing is that the superior mesenteric artery and vein pass across the third part of the duodenum. Therefore, and since they supply the ileum in thin patients, if you apply a tight plaster on the abdomen, they may produce pressure on this third part of the duodenum, leading to obstruction, leading to a lot of vomiting, and this type of obstruction is called as the superior mesenteric artery syndrome. So from here the duodenum starts into the ileum. So this is the duodenojejunal junction. So first the duodenum to jejunum and then to ileum. You see that the inferior vena cava has got a left renal vein. The right renal vein you don't see because it is hidden behind the second part of the duodenum. The next third thing that we have placed here is on the left kidney, the spleen, which is related to the 9th, 10th and 11th rib. So this finishes this diagram, and one more thing that you can see is that the inferior mesenteric vein and has started accompanying the inferior mesenteric artery here. So this is the vascular background that we see in this particular diagram. Now we have placed the head of the pancreas in the C of the duodenum and the tail passing across the kidney into the spleen. So the anterior relation of the kidney would be superior to the tail of pancreas and inferior to the tail of pancreas. Superior is the stomach and inferior is everything below the colon. That means the jejunum and the ileum. So now this pancreas is causing the exiting of the superior mesenteric artery and vein, which is crossing the third part of the duodenum and can cause obstruction here of the third part, which is called the superior mesenteric syndrome. Now, if you take it off, we see here that this is the first part, this is the second part, this is the third part, and this is the DJ junction, duodenojejunal junction. Here is the aorta, here is the inferior vena cava. The aorta is giving a celiac axis, which has got a splenic branch, a right hepatic branch, and this right hepatic branch gives the right gastric, and it gives the supraduodenal artery of Wilkie, and it enters the free edge of the lesser omentum through the porta omentale, gives a cystic artery and divides into the hepatic artery. Then you have the portal vein, which this is the splenic vein, and this is the superior mesenteric vein, and both would combine to form the portal vein, which will again enter the free edge of the lesser omentum through the porta omentale and go and supply the liver. The third thing lying in the free edge of the lesser omentum is this bile duct, which crosses behind the duodenum, combines with the pancreatic duct, and through the ampulla of Vater, it opens in the second part of duodenum. So supposing there's a stone here, then this bile will regurgitate back into the pancreatic duct, will activate the protein digesting enzymes in the pancreatic duct and can cause pancreatitis. So this there's an operation in which the opening of the ampulla of Vater is widened and any stone here is taken off, and that you can do endoscopically. Then you go to the third part of the duodenum, which can be pressed by the superior mesenteric artery and vein, and this is called as the superior mesenteric artery syndrome. So this is what you have got to remember in this diagram. Now we place the colon, the ascending, the transverse, and the descending, and you find that the transverse part of the colon is hanging by the transverse mesocolon from the anterior border of the pancreas. Now this transverse mesocolon has got two layers. It encloses the transverse colon and becomes the greater omentum. The greater omentum turns on itself and then is attached to the greater curvature of the stomach. So it has got actually four layers, and under the greater omentum you can see this ileum, jejunum from the DJ flexure, then the ileum, and this ileum is going into the ileocecal region and combining with the colon. The ileum is primarily supplied by the superior mesenteric artery. So this is behind the greater omentum. So this is the transverse mesocolon and this is the greater omentum. The posterior two layers. It will wind on itself and then come to enclose the stomach and become the lesser omentum. So this is what you see in this particular diagram. So this is the pancreas. These were the two layers which were the transverse mesocolon. They enclosed the colon and became the posterior two layers of the greater omentum, which winded on itself, enclosed the stomach, and then became the lesser omentum. And then this lesser omentum went over the liver and then became the coronary ligaments which attach the liver to the diaphragm. So here is the greater omentum attached to the greater curvature. The anterior two layers. The posterior two layers will go in to the transverse colon and become the transverse mesocolon and will go to the pancreas. The anterior two layers will enclose the stomach and the duodenum, become the lesser omentum and go to the liver. And this free edge of the lesser omentum houses the three structures: the portal vein, the hepatic artery, and the bile duct. And this, you can see the bile duct emerging here and the cystic duct of the gallbladder. Now this free edge of the lesser omentum anteriorly, the inferior vena cava posteriorly, the first part of the duodenum below, and the caudate lobe of the liver above. This is the foramen of Winslow. If it gets blocked, then the fluid fills behind the stomach. The fluid fills behind the stomach, and this is called as pseudopancreatic cyst. Now this cyst can be drained through the posterior wall of the stomach into the stomach. This is called as gastrocystostomy. Gastrocystostomy. So this is the pseudopancreatic cyst, and since the aorta is behind, therefore if the patient is lying, you can feel transmitted pulsations in this epigastric swelling. But if you make the patient into a knee-elbow position, the cyst moves away from the aorta and the pulsations would disappear. So this is the formation of the pseudopancreatic cyst. And then after the pancreas, this is the retroperitoneum, and then this is the mesentery of the ileum. So this is what we have tried to show in this particular slide: the continuity of the greater omentum with the lesser omentum and the transverse mesocolon. On this side, from the stomach, the peritoneum would go and enclose the spleen. That is called as the gastrosplenic ligament. And then from the spleen onto the kidney, which is called as the leno-renal ligament. Leno means spleen. So this is the peritoneal reflection in this region. We have finally placed the liver. The peritoneum from the anti-abdominal wall from the right and the left side is reflected into this ligament, which is called as the falciform ligament. The importance of this is that the lymphatics from the lower medial part of the breast comes through this, and therefore the breast cancer can cause secondaries through this falciform ligament. And then these two divide into a right and a left coronary ligament, and then go posteriorly into the free edge of the lesser omentum. So after placing the liver here and the falciform ligament, you can see the lesser omentum getting attached to the liver in a H-shaped manner, in a perpendicular manner, and then becoming the greater omentum. Now we'll see it from behind. From behind, you can see the esophagus and the stomach, and through this H-shaped fissure they are H-shaped. These are the two horizontal limbs of the H, and these are the left and right limbs, and this is the horizontal limb of the H. So on this horizontal limb is the inferior vena cava, which you can see here. On this horizontal, on this side is the L-type lesser omentum, which is attached to the lesser curvature of the stomach. Here is the free edge of the lesser omentum, and here is the gallbladder. The foramen of Winslow, which connects the lesser and the greater sac, the lesser sac is behind the stomach, is bounded by the free edge of the lesser omentum, the inferior vena cava, the first part of the duodenum below, and caudate lobe of liver above. And when this gets blocked, there is fluid collection behind the stomach, which results in what is called as the pseudopancreatic cyst.